Thank you, Prof. Valentin. Colleagues, thanks for inviting me. Thank you for being in Israel. I brought my wife along. She's a gastroenterologist, and we're loving it. We're really enjoying it here. So, the initial experience with multiple vest implants for supporting vein grafts and cavity surgery. Let's see how we go. Technology. Right, I don't have any disclosures. So, our unit is in the southwestern part of Africa, in a country called Namibia. That's the flag, obviously. And we're the second least densely populated country in the world, with about 2.2 million people. So we've got the desert without the multitudes, okay? And we'd like to keep it like that. Right, as we all know, saphenous vein graft failure is as high as 25% in the first 12 to 18 months after surgery, with late failures more than 10 years, about 50% in non-LAD territories. And SV graft failure is associated, obviously, with unfavorable outcomes. So there are two distinct phases of remodeling, which we all know about. Shear-induced remodeling, it's an early pattern dominated by luminal enlargement, where you place a venous conduit in an arterial environment and it dilates. Secondly, a later phase is dominated by wall thickening and stiffening of the wall, and these two combined increases saphenous vein graft failure. So we started looking at this in the early 2000s when I was a registrar at UCT. As you can see, there's a macroscopic picture of an unsupported and a supported vein graft model in a vein graft in a primate model on the right-hand side of your screen. In the middle panel at the top, macroscopic appearance after explantation, where you have both remodeling, intimal thickening as well as luminal dilatation. And at the bottom of that panel, you can see clearly the mesh graft embedded into the lumen with thin intima and almost no luminal distension. And histological cross-section at identical magnification, showing the marked difference, which is very clear to see. So yet again, thickness of an intimal layer using IVUS in unsupported vein graft 12 months after surgery, and VES supported 12 months after surgery, and this is from Prof. Taggart in Australia. So we've got CT angiograms from 3 different patients, A, B, and C, showing very nice lumens of grafts to the right territory, and then D, obviously the ugly duckling, angiogram of an unsupported vein graft, and this is 3 to 6 months post-surgery, and also from Dave Taggart. So angiography pictures, the right coronary artery 12 months, and in the bottom panels supported, VES supported after 12 months. So our initial experience is 6 months old. We started in November, done about 40 cases. All our patients under 70 years were enrolled into the study. Age distribution is about 46 to 68 years, male to female 3 to 1, and we're doing about 2 to 2.4 grafts per patient, so lima plus 2 to 3 saphenous veins, which is a standard operation. In the panel on the right, you can clearly see multiple grafts. We've got 1 graft going to the right territory and 2 grafts to the left territory, nicely encased in the vest. These 2 panels on the left-hand side is of the same patient that was done in November, and I scanned him on the 10th of April just to get an idea, 6 months post-op, what it looks like. The only concern in the initial experience, you can see clearly the recommended vest distance from the anastomosis should be about 10 millimeters, and this is more 25. And I think it has to do probably with the undersizing and incorrect measurement of that vest. So pitfalls in multivessel stenting, make sure about accurate measurements and use a ruler. I would probably say rather a bit longer than a bit shorter. Beware of anastomotic leaks, the distals. It's incredibly difficult once the vest is on to mobilize the heart and close that distal anastomosis spurter, which will bring you back to theatre. Fashion the lie of the grafts after the cross clamp is off and the proximal is done. So when the operation is finished, you can bend the graft a little bit, make it lie nicely, do all that when everything is done. Don't try to do it before you've done your proximals. Do not use ligate clips on the branches. Tie, oversew them. Tying and oversew them takes longer, but histologically, over the long term, it's definitely going to be better. And do not fiddle once everything is done. Finish the operation, give the protamine, and close the chest. Thank you very much.
Thank you. Please.
It's very interesting. How do you put the vest? You thread the vein through the vest, or you do the anastomose and then put the vest?
I do the distal, okay, and then it's got this little special steel thing which is long enough, and then I put the vest on. Then I do the next distal. I only fashion the vest after I've done all my distals, okay, before I anastomose the mammary, okay. So you must do the vest and the distals and everything before you do the proximals, before you do the mammary, and measure and move them and get them ready, and then you do the mammary, because otherwise, you're manipulating the arch, you're going to pull off your mammary anastomosis.
Yes.
Extremely nice nuance. Do you think it's feasible to perform sequential grafting using this vest?
Probably not, because you have to cut a hole in the vest, which is going to disrupt the architecture of the vest. Okay, so probably not. I was in any case taught many moons ago, one vessel, one graft. So I usually do single vessels to single grafts, or single graft to single vessels. Yeah.
I have some experience in animal, in clinical as well with the vest. First of all, the nice thing is it's very easy to use. It's very not complicated.
It's really easy. Yeah.
Easy. And it's just a matter of time when the company will let us to have show that can work with sequential, and it's just not available now.
Yeah.
Technological, it's feasible to do it. Just you need a smaller steps.
Professor Taggart presented this, I think it was in September in Cape Town, and the closing remark was, of all the novel therapies and everything, it always increased the difficulty of the operation. This really does not increase the difficulty. It makes the operation 5 or 10 minutes longer, and it's easy to use. It's really easy to use. And I firmly believe you look at the histology, it should make a difference.
And it is available for sequential grafting.
Okay, well, thank you for having me.
Thank you very much.
I think we continue with henning on fast tracking.
Thanks. No? No, not this one. Previous one. No. Next one.
You have the remote?
Mm-hmm. No, but this is not. Just give him this one. I want the next one. The one below that. Okay. Can I show him?
Yeah. Thank you. You can beat him as well.